Hello, and I wish to congratulate the 20th anniversary of ICP. It was a grand joy to see it grow and rise in for the committee that organized the council, the Congress, and to Abdi for giving us the opportunity. I'd like to thank them. And I will be discussing the ariprazole long-term treatment in bipolar disorders. Gülçin Erdoğa will be discussing the Gaziantep University double dose applications and its effect on bipolars, and she will be presenting her data. If you excuse me, I will start. As you know, schizophrenia and bipolar disorder is a serious treatment. Conventional antipsychotics has a 40% abandonment rate, which goes up to 75% in abandonment. In all psychiatrics, this isn't apparent, but in bipolar disorders, this becomes much more prevalent. Antipsychotics in the epitech ones, yep, it is pretty much the same. 75% abandonment rate in 18 months. How can we overcome this? Long-term antipsychotic application? Perhaps it is a solution. And 80% of doctors say that the patient refuses. But when you look at the patient side, less than 36% of them are actually recommended the long-term treatment. With 3 months long-term application, experiences of patients were evaluated in a poll. A long-term formulation of antipsychotics and application is preferred method where doctors and nurses are much more in interaction with them since they are much more interactive. They patients say they are more at ease because of the contact with the doctors. They say they live better lives, and this formulation uh, has quote protective shielding against relapse and readmission. Okay, with oral treatments, long term advantages. Well, lower peak points for blood pressure levels, bioconfiguration is in a secure position, dosage and blood level correlations much more predictable, low risk of overdose, and no need for daily intake, which is a prevalent problem for doctors and patients both, but long applications are seemingly better. Classic method starts with oral treatment, and if it's not responding well, long term application. But is this what we see on the field? I say this to patients too when they first get the treatment. Let's say 5% of your brain, I say, it's damaged. On your second, it goes up to 20 and it goes up to all the way to 50, I tell them. Of course, repeated attacks increase in bed time in hospitals, discrepancy between treatment and effect, and abuse of potential abuse of substances, divorces, criminal activity, and public episode outrages, and much more are side effects. As functionality breaks down, it is not a good thing to take precautions then. Precautions should be taken earlier. Boyer and friends from France have focused on 12,000, over 12,000 patients in the French health system and focused on the impact of long-term treatment. We see Abilify Maintena, we see paliperidone LAI, first generation LAIs, and long-term risperidones were measured. Incompatible patients, as expected, long-term antipsychotic application results in, well, a cohesion established, and so emergency and hospitalizations decrease, as expected. However, when we look at cohesive data, we see Abilify Maintena is seen much more effective. We see psychiatric hospitalization has decreased 20%, but paliperidone and risperidone LAIs, in terms of hospitalization, have a 25% increase. When looked into, one possible explanation is that the tolerability profile, little to no side effect. It's both agnostic and antagonistic. So in LAI, dopamine oversensitivity psychosis risk is decreasing. A study from Korea, it is focusing on the effectiveness of switching to long-acting injectable aripiprazole in recent onset chronic schizophrenia. 25 patients, LAI, paliperidone, palimitat, 30 from oral aripiprazole, and 27 are in second generation oral antipsychotics, and they switch to Abilify Maintena, and we can say 45 of them are onset schizophrenic patients. First years are crucial, of course. In first 5 years, once the adaptability of the patient comes in and when the attacks start decrease, the functionality continues, less losses happen. So first years are much more critical in this sense. Abilify Maintena switch, be it with pulse clinical scoring or PSP scores or social interactivity or the ratio of simply what we call patients saying I am fine has increased overall. North Europe, as you know, they have a 50 to 60-year-old historical health records, mental health records, and this is from Finland. For 20 years, 62,000 schizophrenic patients were observed, and relapse signatory rehospitalization rates were adjusted. Clozapine and aripiprazole, in terms of psychotic results or hospitalization, we see it's on a constant decrease, and it's the least. Compared to other antipsychotics, it is seen as better, and with resistant schizophrenic patients, we've seen an advantage, but clozapine usage alone seemingly is not enough. In global and Turkish studies, risperidone's inclusion or inclusion of other pharmaceutical has given the positive returns from patient side. So combinations of things like clozapine decreased the hospitalization. Wang and friends have gone double dose application of Abilify in a study. Day one, therapeutic plasma concentrations were found. Clinical activities dosage intervals were continuously implied. It's seen as secure and tolerable. Oral treatment and single dosage use, oral treatments, pharmaceutical cohesive, medicine cohesive problems have been eliminated. And from side effect profile, aripiprazole, LAI, double dosage, high dosage rather, for long-term use, we see schematic SMQ, we see the differential. Also, in total EPS, we see a similar profile emerge. REACT study, Canada and Germany has seen 396 schizophrenic patients and their functionalities continuation were observed. Two main parameters here. One is under or over 35 years old. Third month and 6 month evaluations of Abilify treatment has shown the functionality has increased. And less than 5 years and longer than 5 years, patients were also segregated here, especially in terms of effectiveness of application. In 3rd and 6 months, the functionality has substantially increased in graphs. Okay, do we get to keep the patients in treatment then? Well, with aripiprazole treatment, 4-year follow-up from Italy. First step, domino 1, and on 48, we see domino 2. We see Abilify Maintena has kept 69.6% in patients, and we see that from 86 to almost 70, decrease, but tolerable decrease. Long-term studies data were complied in an analysis of registry data. Double-blind placebo-controlled tests or real-life data have both been utilized for much more effectiveness. In search, we see clozapine oral as number 1, obviously. Olanzapine LAI, second. Aripiprazole LAI has been seen as third best achiever in this graph. Substance abuse and addiction from 2000s onward, be it for bipolar or for schizophrenic patients, there has been many comorbid work. Substance abuse was always 1 to 3%, but in Western studies we've seen around 40. So we were having a difficult time comprehensively adjusting the understanding to what is substance abuse or addiction. But, well, analysis has developed, and in schizophrenic patients, single dose or double dose usage of apipstapol, we've seen a clinical success in decrease and seen as much more secure and maintainable. Okay, aripiprazole double dose usage and the doctor's output. This is a Satisfy study from Spain. Doctors say that this application shortens the time spent in hospital for a patient, but for security and tolerability has given a positive image. As with patients, doctors are also in a good light. Mismatch. We see almost 64% of misadjusting prescriptions, and doctors know that as with schizophrenia, bipolars are also going through rather degenerative problems, but preventing relapses with LAI antipsychotics, they have become a useful tool in overall improvement of treatment. Compared to other LAIs, it has less metabolic effects, aripiprazole, and also second generation side effects are also much more tolerable and maintainable. For bipolar treatment, disorder treatment, in up-to-date guides, we see aripiprazole acute mania and karma panics have been optional, and also as first step, it is regarded as an acceptable method of treatment. This patient group, as you know, is often misprescribed. Aripiprazole LAI, and for 14 days, continuation of oral treatment between 10 to 20 milligrams is a challenge in and of itself. Convincing patient, the relatives of patient, gaining their support, of course, was a challenge always. But with a new application, European pharmaceutical agencies said in 2017 onwards have approved an alternative to injections application. 120 milligram oral aripiprazole is given to the patient. Tolerances are measured. Negative side effects are evaluated. And with gluteal and deltoid muscles, 2 dosage of 400 milligram injections are applied after. A Turkish study from Ege University, Sungur and friends, focuses on double dose injections, start treatment, psychotic and karma complex, 8 level, many cases. Of course, the sample size is little, but this pre-report shows that double dose injection starting treatment is much better tolerable, as reported by patient. An Italian study, Cuomo and friends, have focused on Abilify Maintena double dose 103 patient case, has reported no major side effects on patient. Of course, some worry always applies with double dose. We were afraid of a potential mass increase in side effects. I was more cautious and I waited for Gülçin, and honestly, there was no serious side effect, and the functionality of patients and the medicine both and the clinical scores have been improved, and we got the courage based on this output. Security and tolerance is seen as same as oral application and single dose injection. From Gaziantep University, 44 patient double dosage aripiprazole long LAI starting treatment. Compared to single dose, we see manic depressive scores have decreased rapidly, much more rapidly. Side effects in both group were in tolerable levels, and there were no life-threatening situations in terms of side effects. Aripiprazole, in terms of schizophrenia and bipolar disorder treatment, is a strong antipsychotic. In long LAIs, it has a significant profile. Abilify Maintena long-term with rapid observable treatment, oral treatments, single injection can be overlooked by double dosage application. Thank you all for listening. If you wish to have a comment or a question, I can take it. Or perhaps Miss Gülçin can have a presentation and we can take them together. I would like to thank him because he laid the foundation for me to jump from, and I will be focusing on what we can see ourselves. Okay, and I also wish to congratulate ICP's 20th year anniversary because you have grown and enlarged. We have a memory logbook and people are writing down their memories. I want to touch upon mine. The fourth Psychopharmacology in 2011, Abdurrahman was also on stage, was presenting. And before that, he wanted me to prepare, but I came up with a draft only. He expanded on it so much, but he reflected on that. And when he was presenting it, I saw my name next to his, and I felt such a joy. I mean, nobody probably noticed that, but that day, I said, my teacher has given me the life I will live. And this is, I believe, the same for doctors and patients. When they are diagnosed and or when they see symptoms, patients feel like they're in the dark. We, as doctors, as mentors, give them their life with limited resources we have, but with the strong therapeutic relation, we want to and do want to make it better to patients and feel heart to heart, as it were. That is why I correlate both. We talked about bipolar disorder, schizophrenia. Absolute cure is not coming anytime soon. Again, can medicine do it? Can we do non-medicine follow-up for schizophrenia? It is a courageous decision to make, but patients themselves impulsively, instantly can drop any and all medicine they want to take. Even though we cannot talk about an absolute cure, as much as we can keep the symptoms in control, prevent relapses or emergence of attacks, we keep their individuality, functionality, take precautionary measures, and improve the quality of life, which is our absolute goal. Even our best profile patients may see mismatch in treatment as if it is the rule. Many practitioners and doctors, we see teachers, students, everybody can be a patient, and they say, oh, I stopped taking the meds during the exam week. I have a girlfriend, and this medicine has sexual side effects, and I don't want to use it, yeah, etc. And they willingly decrease that. Even more so, they come up to you and say, I don't want to use it. But third to fourth, I'm going to say everybody always focuses on decreasing the dosage or stopping using it. You can ignore these, or you can work with your patients and find a proving ground, a midpoint to meet. We have advantages, however, especially in side effect profile, the metabolic side effects. Even though you present something that can be overlooked by all, a sustained treatment procedure with patient is challenged. So, in that sense, we have an advantage here. Bipolar disorder, schizophrenia, etc. After the first attack, regardless of what you do, the previous state, it is impossible, almost impossible to achieve, and repeated attacks degrade this low chance even further. When we look at the global scale, we see something called DALYs. What is DALYs? You can see that disability adjusted life year, how it is calculated. Everybody has an expected life, let's say 85, but with comorbid sedentals or metabolic syndromes and everything else, this decreases to 60s, 65s, lose 20 years of their life. Bipolar disorders, let's say, they have a manic attack for 2 years, 2 years decrease in functionality. They recover, work a bit, go into depression, 6 months gone. In global scale, when you look at to all of these, both to individual cost and the global cost, has been measured in this to have a common tongue, a common measurement for all of these. Any subparameter you can have, developed or undeveloped nations, etc. In developed nations, we see cancer, cardiovascular diseases, and mental disorders are really bright on the graphs. But in underdeveloped nations, we still see infections, diarrhea, neonatals are prevalent. This chart gives varying messages, developing global or national health policies or industrial movements. We simply say we have a lot to do here to change this graph, but we have limited agencies. So, what can we do with what we have? We see bipolar disorder, schizophrenia, and others are mostly seen where one person is most active, 30s. Schizophrenia is number one. Bipolar disorders and other disorders are listed as third or fourth year on this graph. And today's session's main theme emerges from this. Yes, LAIs give us advantage. Aripiprazole, when it comes to effectiveness or metabolic side effect with a good profile and sustainability, we have advantages. But there's an application problem. So in classic regime, what was the traditional? Day one's injection and 16 days with oral supplements. Why? To have the therapeutic blood infusion levels. So can this be managed with every patient? I mean, we see negativity already emerge from the word treatment. I mean, most patients don't want to be in ICU. Well, we just assume that they take their medicines as ordered and we work from that. But resistances or negativity and feedback now have become much more prevalent. And these days, we are recommended double dose application to eliminate the necessity of oral intake, which is regarded as an advantage for us. As 20 milligram single tablet and single injection, and compare that to double dosage with no oral intake is much more appealing. I mean, we have a motto, first and foremost: doctors do no harm. And well, we have long LAI, Abilify Maintena, even doctors that used that 40 to 50 years ago were hesitant then. And now we're talking about double dosage. Are we going out of the therapeutic index? Am I creating a toxicity within the body? Okay, we have a research here by Wang and friends, which shows us a route to follow. This red wave is from double dosage, and we see the blood concentration here. The other blue and black waves are 10 to 20 milligrams of 14-day oral intake and single dose injections. Four different graphs. Why? Four extremities and different combinations emerge. I sometimes tell to my nurse, and she asks, do I do both injections from the same spot? No, we prefer different spots for double injections, but the graphs are pretty much the same. And again, we see some messages, especially in double dosage, blood concentration level, the red line here, it is not as feared and does not go over the therapeutic index. We see also that the single dosage usage and oral supplements, which we feel safe, the fluctuations in blood concentration, you can see the wavering, the waves have even larger heights. Another message, when it comes to blood concentration levels, we see them in day 9 or 10, much earlier than before. This gives us even more messages to look into, but do we settle in? No. In pharmacokinetic models, may not always match with the clinic. When I do a double dose application on a patient, a reaction or side effect, no arrhythmia or anything. Clinics have much more worries. So, multicentral studies help us in this regard, give us guidance. This is about schizophrenic patients, double dosage compared to single dosage, 24 hours and 30 days later observation. And in terms of security and tolerability, both groups show similar results, and no serious lethal reactions have been received from the administrations.
Baktığımızda daha çok görülen taşikardi, tremor, akatizi %10 civarında. Yine libido azalması, erektil disfonksiyon aslında diğer antipsikotiklerle kıyasladığımızda çok daha avantajlı, düşük oranlarda. Peki Mosley bu konuda ne diyor? Arada bazen bana sorular geliyor. Bu uygulamayı siz mi yaptınız? Hayır, aslında zaten bu mevcut bir literatür bilgisi. Sadece ülkelerin ruhsatlandırma çalışmalarına göre pratiğine girme süresi farklılık arz edebiliyor. Yaklaşık 2 yıldır da biz kendi pratiğimizde ruhsatlandıktan sonra kullanmaya başladık. Mosley de bu konuda aslında detaylı bilgi veriyor. Nasıl geçilir, tek enjeksiyonlu başlangıç nasıl yapılır, çift enjeksiyonlu başlangıç nasıl yapılır diye tek tek bize tarifliyor ve şöyle de bir parantez açıyor. Eğer hastanızın oral ilaç reddi varsa her zaman 2 enjeksiyonlu başlangıcı tercih ettin. Hatta o başlangıçta 1 adet 20 mg verilme zorunluluğunu bile gerekirse pas geçebilirsiniz. Muhtemelen etkili kan konsantrasyon süresi duyusuna bir süre sonra ulaşacaktır diye bir mesaj da veriyor. Tabii ki tüm ilaçlarda olduğu gibi oral tolerabilitesini daha önce bilmek şartıyla. Yine hocam da bahsetti. Evet, madde kullanım komorbiditesi artık çokça karşımıza çıkıyor ve gerçekten psikoz hastalarında da işin rengini oldukça karıştırıyor. Tedavi sürecini çok zorlaştırabiliyor. Peki burada bize bir avantaj sağlayabilir mi? Bununla ilgili çok yeni bir çalışma, 2025 çalışması. Madde kullanım bozukluğu olan ve olmayan psikoz hastalarına bakmışlar. Ve yine çeşitli yaşam kalitesi skorlarında veya klinik ölçeklerde olumlu sonuçlar olmakla beraber daha çok ben dikkatinizi aşerme craving skorlarına çekeceğim. Burada craving skorlarında çift dozda başlandığında çok şiddetinin ve sıklığının çok daha erken dönemde azaldığı yönünde bir veriyle karşımıza çıkıyor ki bu da bu zor yönetilen hasta grubu için bir avantaj olabilir. Bu da yine o çalışmadaki kan düzeyleri, yine kırmızı olan çift enjeksiyonla uygulama istenilen terapötik aralıkta çok hızlı bir şekilde ulaştığını görüyoruz. Evet, Türkiye'den de böyle hızlıca çalışmalar geliyor, literatüre katkıda bulunacak. İlki işte İzmir grubundan Eker ve arkadaşları tarafından geldi. Bir 8 hastalık vaka serisiydi. Literatürden farkı hep şizofreni ve psikoz hasta grubunda çalışmalar dikkatinizi çektiyse bipolar bozuklukta, manik atakta etkili ve tolere edilebilir olduğunu ve hatta hastane yatış süresinde kısaltılabileceği yönünde böyle bir ön bildirim çalışmasıydı. Biz de az önce hocamın bahsettiği gibi Gaziantep Üniversitesi'nde 50 hastaya yakın bir seri topladık. Burada da yine akut dönem manide çift doz ve tek doz uygulamanın avantajları var mı, klinik yansıması nasıl, yan etkide ayrışıyor mu? Bunu gözlemlediğimiz bir çalışma oldu. Hem çift doz hem tek doz uyguladığımız grupta kadın erkek dağılımı, yaş açısından benzerlik vardı. Yine psikotik mani, karma mani olması açısından bir fark yoktu. Hastalığın ilk atak olup olmaması da benzerdi. Sadece hastaneye yatış öyküsü tek doz grubunda bir miktarda anlamlı olarak fazla çıktı. Ve klinik yansımasına baktığımızda bakın akut dönemde 15. günde YMRS skorlarında anlamlı olarak çift doz grubunda hızlı bir düşüş görüldü. Diğer skorlar da olumlu seyretti. Yine psikotrop yan etki değerlendirme ölçeğinde de ciddi bir reaksiyonla karşılaşmadık. Birbirine benzer özelliklerde sonuçlar elde ettik. Tabii bunlar akut dönem hastaları, akut manide. Dolayısıyla diğer ilaçları, duygu durum düzenleyicileri, gerekirse benzodiazepinleri veya diğer antipsikotikleri devam eden hastalardı. Onlar da her iki grupta benzer özellikte devam ediyordu. Peki 15. günün sonuna geldiğimizde ne gibi yan etkiler oldu? Bir de onlara bakalım. Ne bileyim, akatizi riski arttı mı? İşte baş edilmeyen bir sorun karşımıza çıktı mı? Hayır. Bipolar hasta grubunda da tıpkı şizofreni gruplarında olduğu gibi akatizi işte %8.6 gayet kabul edilebilir bir oranda ve baş edilebilir düzeyde bir akatiziyle karşılaştık. Onun dışında tremor, bir miktar taşikardi. Bunlar gözlemlediğimiz yan etkilerdi ama ciddi bir yan etkinin olması, kontrol edilemeyen bir yan etkinin olmaması bizim için rahatlatıcı oldu. Bizim verimizde daytime sedasyon, uykululuk bir miktar fazla çıktı ama işte akut mani hastalarının bizim sedasyon ihtiyacını karşılamamızla ilişkili molekülden bağımsız bir sonuç diye onu da değerlendirdik. Yan etkilerin hafif ve ılımlı düzeyde olması bize bazı kapıları araladı. Bunlar nasıl, nedir? İşte nedir o YMRS'deki hızlı düşüşü görmemiz, semptom şiddetine hızlıca müdahale ediyor olmamız aslında belki hastaneye yatış gerekliliğini azaltacaktı. Hastaneye yattıysa süreyi kısaltacaktı. Ve global baktığımızda aslında tedavi maliyetinin düşüşü, global yükün azalması ve o bahsettiğimiz ilk baştaki grafiğin belki tersine dönmesi açısından sınırlı araçlarımızla yapabileceğimizin bir daha iyisi gibi görünüyor şimdilik. Tabii bunlar yeni çalışmaları da kapıyı aralıyor. Konuşmanın başında konuştuğumuz gibi. Biz de böyle bir kapı aralamak istedik. Ben katkılarınızı bekliyorum. Eminim çok da sizlerin de tecrübeleri olmuştur ya da sorularınız vardır. Teşekkür ederim.
Deneyimi olan var mı?
Anyone who has some kind of experience about double dose application or double two injection. First of all, I would like to thank for your presentation, Dr. Ayşenur from Pamukkale University. We have an experience for around 30 patients. I can't hear, she says. I can't hear, she says. Microphone is not working. We had a double dose with 30 patients, and it was accepted, just approved just 2 days ago. Bipolar and schizophrenic and schizophrenia patients were included in this study. And quite interesting, on the 5th day morning, there was significant differences in the clinic. And we were just making estimations with our assistants, and except for one patient, we had a very quick recovery. and double dose injection. The hospitalization period mean time was 11 days with the double injection, 2 injection. After the 11th day, we were dehospitalizing for a schizophrenia or a bipolar patient. That's a good increase in the quality of life, getting back to normal life and to social life, and they can recover quickly. And for functionality, our experience and clinical monitoring is improved. And for 29 patients, first injection was on the 8th of March 2023. It has been 2 years, and in this 2-year period, none of our patients maintained injection for 2 days, and there was no dropout, and it was continued for 2 days. Thank you for your contribution. That dramatic improvement gives the patients in promising, and they are more encouraged to continue to adherence. That's a good experience, I believe. Thank you. One question from the first row. An audience on the first row wants to have the microphone. Thank you very much, esteemed doctor. It was quite a good presentation. First of all, let me tell, during the meetings, all these romantic things that we discuss and tell, make 2 injections, we haven't been able to settle this one single dose yet. From 10 years of psychiatrist, physician calls me from with an experience of 10 years, and I want to prescribe Maintena. What is the procedure? How should I prescribe it? He asks, a doctor of 10 years experience. Such an important medication, and it's in Turkish market and available. My personal experience, let me tell, when Maintena appeared, I saw no attacks in my bipolar patients. It's a super effective drug, but still in universities or other places, no naming. You are working in a university, but assistance in Litrol is still preferred. Yes, you can prescribe Litrol, a certain brand of medication. I have an experience of 40 years of psychiatry. We have prescribed Litrol for many years, and we are still prescribing. But when we have such super effective medication, even our physicians haven't been able to learn using single dose of this medication. I'm not very optimistic, but hopefully if they use double dose or 2 dose, I would like to request you to say a few words, because we have young colleagues. Do they use single dose even, let alone the double dose? So, introduction to Turkish market. It has been 8 to 9 years in Turkish market, and during the training, if they were not exposed to the training, and when they go at experts, if it is not diagnosed previously, then they may have hesitations to prescribe. That's why it's important to meet and together, and the sharing of experience among colleagues. It's a process, and it will take time. There's a significant problem here, and I see in many of the cases there is as if each bipolar patient, a mood stabilizer needs to be started. That's the perception. But for 10 to 20 years of studies shows that antipsychotics alone can prevent the patient from relapses. 3, 4 medications in many of the patients in their prescription. The more medications, the more adverse effects that means. And there was one patient who was imprisoned and who for a crime, and there was one psychopathic medication, and they were asking, how come you could be good with single medication? And I believe during the congresses or general training activities, this misinformation or disinformation needs to be corrected. Of course, mood stabilizers can be used or added on. They are good options. But for myself, for schizophrenia and for bipolar patients, I do my best to reduce to single medication. We can make it in some patients. In some, we cannot. There are multiple medications for in early stages of the illness. It's successful. But if it's a 20, 25 years of, and they have been hospitalized for 10 to 15 times, then there are cases where we use 3 or 4 medications. You are right. Cooperation and training activities and disseminating the correct information is important. Over to Mesut. Dr. Mesut. Thank you for this good presentation and quite enlightening. And as Professor Ayhan says, not widely known. This needs to be further emphasized and explained. for the beginning, you should try oral. Do you directly go for injection, or ideally for a long term, oral tolerability needs to be understood first. But practical implementation, there can be challenging times to do this. What do we do here? This is not a directly recommended method. For like 1 week, you remain in oral intake and observe. Sometimes this oral intake period can be observed for 3 days, and if there is no there can be significant acatisis, but the long-term medications has a significant, not just adherence to treatment, and that's not just the only objective or goal. Our optimal blood serum levels is obtained because for oral intake, although ariprazone half-life is 75 hours, metabolites are much longer, and there is not much of a remission, but still yet there is blood level peaks, and at the peak level then you have adverse effects, side effects. That range or optimal D2 receptor retention, we can make it, but here, as far as I know, in Turkey, it's 400 milligrams available in Turkey, but in overseas or other countries, there are 4 different dosages, smaller 300, 116, 200 something, 4 different dosages. They need to be also introduced to the market for common use. Some patients may respond to lower dosages, and higher dosage would go beyond the peak of blood level, and the side or adverse effects could emerge, or that can be needed for maintenance, or adherence is bad and for some rejection at least once in a month, as like a circuit breaker or like a vaccine, vaccine-like. Is this double injection to one deltoid? No. If possible, from different extremities we prefer. The 4 extremities can be used, but cross application, right deltoids and left gluteus could be preferred, cross application, but no significant problems up to preference. Is it deltoids or it's single dose per month for continued? Some patients may have weak deltoids and volume could be less, therefore gluteus, but in the gluteus there is hesitation, but some convincing and adherence. We have some flexibility there, room for flexibility. If they have enough volume on the deltoids, that is much better for weak patients or women. I do injections in my clinic sometimes. We prefer gluteus, but depends on the patient preferences, urban or rural, conservative or more open. 300, 400 milligrams. Some can be, I'm satisfied and I do not have relapses, but it seems a little bit too much for me. There were a couple of patients, they were bipolar patients, and I also consulted with the company for this, and they say, let's say 400 and first, and later on we will introduce 300 or other dosages. Here, maybe I didn't know before, and it was mentioned a while ago, payment method. If you have 2 injections, is it paid by the Social Security system? You need to specify this in the report, medical report for the medication. 2 dosages for initial and 1 time later on. Both the hospitalized inbound and outbound patients, it can be compensated or paid. Professor or Dr. Mehmet is my previous assistant and now in Diyarbakir. Thank you. Thank you very much for sharing of this experience. I have benefited a lot from this presentation. My question is, this two injection and single injection experience. We have a lot for clinical. Some patients after application, after injection, some patients has very good anxiolytic effect. Did you have such kind of experience? We had these results, both the single injection, double injection for bipolar and schizophrenia patients immediately after the injection or application. Around 2 hours later, there were anxiolytic effect starting. At the end of the first day, after 24 hours, a very significant and visible anxiotic. We don't see it in all of the cases, and there were cases, we were expecting akathisia, but this was good to see this. Our study raw results also on the 15th day, there was significant reduction, decrease, anxiety-related symptoms there also, at least depression scores are decreased. For agitated patients, there is such relief. And there is an overall decrease in the anxiety, but we haven't verified it and not measured it with an anxiety scale, but observations, clinical observations shows in some selected cases, yes, we have similar observations. It's quite interesting. This akathisia is not as much as the oral intake, both for double and single injection. Yeah, that's true. I agree with that too. That's my conclusion too. Thank you very much for presentation. Dr. Furkan from Ege University Psychiatry Department. Being a psychopharmacological congress, I would like to retribute to lithium. We use single dose and double dose, but unfortunately lithium was not available in Turkey. It was like an orphan drug with clozapine. When lithium was not available, they were not suited with ipaclizole. This combination of lithium, and it's still at the front line. The lithium's impact or efficacy not less than ipaclizole. I wish we could have the remission of all patients with this medication, but many patients needed additional lithium. I worked in lithium. They like lithium very much in Ege University. A group of patients recovers only with lithium and they can remain on remission. But I am mood stabilizer to be used for all patients. I'm against this. And they have a role to play and they have the time to use, and it's the first line treatment component, but still needs to be considered. Standardization is not very good, I believe. Lithium standardization. A couple of patients I had reporting to the Ministry of Health together with the batch number and serial number of the drug, because it was like some extreme high dosage, because some were even fainting or they could not even stand up, failures. High dose not given, but standardization of the dosages. Instead of that is long-term impact lithium that is imported through Turkish Union of pharmacies, but not available for all patients. I have been telling for many years for the companies this long-term forms needs to be produced, manufactured in Turkey. This lithium was discussed in one of the previous sessions, low dosage lithium. And with low dosage lithium, many of the episodes could be prevented. Another characteristics of lithium is anti-suicidal effect. This is a verified with clozapine, these two medications. And based on my experiences, I can see this for resistant depression. You can overcome really the suicidal risks, and it's protective. And response to treatment and resistance to treatment. lithium should be correct. Patients should be selected, and I'm even naming not a very good drug or medication, maybe, but this retard effect, a single dose a day lithium, that's very good, retarded effect. And if available and if affordable, and Turkish Union of Pharmacists is also bringing it to Turkey, the retard form. That is 600, 450. Some patients, for instance, instead of 4 times a day, you give just 2 times a day, and it has a psychological impact. It's very promising and satisfying for resistant depression. Some patients even ask, why haven't we used it? You don't start it for all patients. A low dosage from clinical, they can be sensitive to the side effects like tremor, and you reduce the dose and it goes, and it works. It works even in low dosage lithiums. Thank you very much for your active contributions, and I would like to thank each and every one of you. Thank you very much.